Pediatric sleep medicine is in its developing stage. There are still unknowns, but we know there are a lot of consequences to children who have obstructive sleep apnea. So one of the main problems is to diagnose these children timely and also manage them individually. So we have problems with access to gold standard diagnostic method, which is polysomnography, and it's also expensive and a little bit invasive for especially smaller kids. So one of the unmet needs is in diagnostic area. And the other area is not all children respond to adenotonsillectomy, which is the major cause for obstructive sleep apnea in children. So we want to know who is going to respond to this treatment modality and who will need additional treatments. So a stepwise approach that is now being developed by a lot of researchers and clinicians is another challenge and unmet need in this area. We've been working a lot in diagnostic area for children with sleep disordered breathing. So one of the developments has been diagnosing these kids or screening these kids with abbreviated methods, such as using an oximetry, overnight oximetry, or using a polygraphy, which is a simpler sort of polysomnography without the EEG leads. So we've been making a lot of developments in this area. Even in smaller kids, we've been able to use polygraphy and diagnose them timely or screen them so that they can manage to have an earlier treatment. And also for oximetry, there are now studies using smartphones and combining this with an oximetry and using those overnight in children with suspected obstructive sleep apnea. And this can be a really easy, very approachable and cheap method, and it looks very promising. The major risk factor for obstructive sleep apnea has been traditionally adenotonsillar hypertrophy. This is still a major risk factor, especially for younger kids. But now with the obesity epidemic in children, we have been seeing more and more adolescent-age children with obesity and obstructive sleep apnea. So these children are less likely to respond to classical treatment with adenotonsillectomy and require maybe modalities such as weight loss or non-invasive ventilation, more so than younger children. And recently we have been discovering that having parents who have obstructive sleep apnea, who have a history of adenotonsillectomy, and being born prematurely are also significant risk factors, as well as some ethnic differences. So some ethnicities may be more prone to have obstructive sleep apnea. In adults, CO2 monitoring is not a routine test during polysomnography. But in children, both the American Academy of Pediatrics and European Respiratory Society have been recommending using carbon dioxide monitoring during polysomnography, thinking that children may be more prone to have hypoventilation as opposed to adults. Some recent studies, which are retrospective and limited but still very good quality, suggest that this is important, especially for children who have comorbidities. So a routine child who has obstructive sleep apnea symptoms but no other associated morbidities may not benefit from CO2 monitoring greatly because it adds additional cost to the study. But if you have a child who has a syndrome such as Prader-Willi or Down syndrome, or has other comorbidities and also obesity, the child may benefit from CO2 monitoring.